One of the most common things my patients ask me about are what are the most natural ways to treat allergies? Welcome back to
Allergy Actually.
And today we're going to be talking all about immunotherapy, one of the ways that we're able to really treat allergies at their root cause. And it's not just allergy shots anymore, although that is the mainstay of immunotherapy. So we're going to dig into the science and all of the different types, little compare, contrast.
I guess just at a kind of basic level, the whole concept of immunotherapy is we're taking something you're allergic to. So, if you're allergic to pollen and dog dander, we can take those natural, purified extracts of those proteins, mix those together and administer them to you in different ways. And that's what we'll talk about, the different ways. But when we administer that, over time with repeated exposure, your body gets used to it, gets desensitized or builds a tolerance sort of. So as your body gets used to it, your immune system learns that these things are a normal part of your environment, that you don't need to create a huge inflammatory cascade when you're around them. And over time, you don't. So you have less and less symptoms, you need less and less medicine, and that's the whole point. It's a natural treatment for your allergies.
Yeah, it really is the most natural.
And it's also treatment that we've had as allergists for the longest period of time. I mean, the allergy shots and oral or under-the-tongue administration of allergens has been looked at scientifically since the early 1900s.
Mm-hmm. Right.
Yep.
Yeah. I always describe the regular allergy shot. So that actually, in an allergist language, we call that SCIT, SCIT, so subcutaneous immunotherapy. And what we're doing is basically putting a shot, which contains a small amount of the allergen, that over time we increase to what we call a maintenance level, which is where research has shown us that that is the right amount to induce your body to do that, make what it needs for that non-inflammatory response, but not so high that you're likely to react to it. So that's the goal. But I always tell my patients, basically what we're doing with that is putting a shot in typically your arm, so the fat of your arm. We wait for immune cells to come and take that allergen to the lymph node where it learns what it should actually be doing in a non-inflammatory way. And so the thing about that is that it is a wonderful option. It's very time consuming. And in order to have effective shots, we talked about that effective dose. According to the guidelines for immunotherapy that allergists tend to follow, that's not something that people should be doing at home because it can be dangerous because we're literally giving you a shot of something you're allergic to. So when you're in a controlled condition, such as your allergist office, where they're trained to treat and recognize bad allergic reactions, that's where you really need to receive it. So I'm always suspicious of someone who does shots at home, and I wonder if truly what's in it is what you actually need to get better.
And my question for you is, what risk do you usually tell patients? If someone's interested in shots, what is the rate of having one of those reactions? And why, why we say you need to stay in the office for 30 minutes after your shot so we can watch you.
Right.
Yeah, it's rare. It's rare, but it can happen. And what we worry about the most as physicians is protecting our patients, first doing no harm. And so we don't want anyone to ever die from a treatment that they're receiving. But when we look at the data of fatalities in immunotherapy for SCIT, every 1.25 million injections, which is a small number, but still there can be fatalities. And a lot of that, when they look back at the data, had to do with either home injection, which is why we no longer allow that, or delayed treatment with epinephrine if you start having a reaction, which again, oftentimes would happen at home. So there are reasons why your allergist today says you have to get your shot in my office or in your doctor's office, someone's doctor's office, so that not just because you need to have someone who knows how to give a shot, that's the easy part.
Right.
It's the treating the worst case scenario and making sure you're safe.
And we do a 30-minute observation period because there was research that showed, I believe it was about 95% of reactions occur within that 30-minute time period. And so that's why most of us default to 30 minutes. And I also give my patients some additional instructions. I do like them to take an antihistamine the day of the shot because it can decrease localized itching and discomfort. The other thing is I tell people not to exercise, and I can't remember exactly. There are differences for people, but about 4 to 6 hours. I remember when I was a fellow, we had a patient that tolerated their shots very well, but when he was on his way home, he reacted every time. And we finally figured out he was riding his bike. Do you remember that?
Oh my
He
gosh.
was riding his bike home. And so I tell people, I mean, it would be a minimum of 2 hours of exercise. But again, it's different for different people, what I choose for that. And that's hard if you're an athlete and, you need to leave and go straight to football practice, which leads us to other methods that are less time-consuming than doing regular subcutaneous immunotherapy.
And before we move on, what is the time commitment?
So the time commitment is actually typically it starts out at a minimum, 1 shot per week, and depending on how that's tolerated, it takes about 6 months to a year to build up to maintenance where you're at that highest dose, and we can then stretch it out from weekly to once a month. There are some caveats, as in we can have you come in and do some extra shots all clustered together in a day. There are some ways to make that quicker, but you are still going to the doctor's office at minimum for the first 6 months, 30 minutes, and that doesn't actually count like driving there, arriving, getting checked in, all of that. We try to make that as painless as possible, but it's still a consideration.
And then it's monthly for 3 to 5 years or longer.
Yep, absolutely.
Okay. So as I was transitioning out of training, it was an interesting circumstance. This was back in 2016, 2017, and we were just starting to see the approval of some under-the-tongue tablets for allergies. And it was in a unique kind of situation was at Ohio State. And within the field of allergy, there are mainly 2 types of physicians that will provide allergy care or call themselves allergists. There are folks that have gone through our kind of particular pathway, which is either internal medicine or pediatrics, and then a fellowship. And then occasionally, ear, nose, and throat surgery doctors also have had some role in treatment of allergies. And in that area and within ENT, there was an increased use of allergy drops. So the same raw materials we would use to mix up for shots, but ENTs were a little more likely to administer that as a solution under the tongue. Back in 2016, 2017, that was considered quite taboo within our area. And when I was hired on faculty, it just so worked out that there was an ear, nose, and throat allergist who was looking to retire. And so it was in my contract that I was going to take over this sublingual immunotherapy program or SLIT program.
Scandalous.
It kind of was at the time,
really
professionally
was.
speaking. Yeah. That being said, I always was interested in, because frankly, what I realized is if I had just become a mom, but like the idea of having to take my kid to the office like once a week or myself to the office, like I was like, who in the heck has time for this is not to mention, I don't like needles. Like I was actually more scared of the epidural needle than I was, the actual birth process. Anyways, so I was always open to this idea of, are there other ways? And, what we've come to learn too is that the oral mucosa, the mouth, the gut, it is more primed for tolerance. We think of little kids when they're learning to eat and explore their environment, everything's going in their mouth. So that kind of made some sense too.
It's how your body learns what's normal.
Yeah. So suffice it to say, sublingual immunotherapy, or SLIT, SLIT, became a pretty big part of my practice early on in my career and kind of continued to head that up while I was on faculty at Ohio State. My initial impression was gosh, this is so much easier. You take it at home on a daily basis. No big deal, right? Adherence must be so much better. But when you look at the data, adherence is actually equally as dismal for showing up in the office, once a week and then once a month.
Isn't that surprising?
It is, but then it isn't, because when you think about human behavior, it's really hard for us to do something over and over and over again, whether it is weekly or monthly or daily. And to keep that up, so the time commitment is, again, 3 to 5 years at least. We have a little less guidance on kind of those targets we need to hit from a dosing standpoint, though that has come into its own a bit better the last 10 years or so. But what are some of the other advantages? So yes, you do it at home. So it is safer in the sense that we see less risk of a systemic or anaphylactic reaction. Typically, that first dose is done under some sort of medical supervision. And the other aspect that is different is that unless you are being prescribed an FDA-approved tablet, which is available for dust mite, for grass, and for ragweed, typically, sublingual immunotherapy will not be covered by your insurance plan. Even though we are using the same ingredients that are approved for shots. So it's frustrating, but it is where we are. When you look at kind of the risk appears to be less, convenience for home seems to be better, effectiveness, that's the question. And, at least is how I've read the data. I think when we look at seasonal allergies, pollen, grass, trees, weeds, to me, that data looks a little more equal. And maybe, especially with pets, we don't have as robust data to say that, yes, it is as helpful. So this is where I think that knowing yourself can be really helpful. Are you someone who can show up every day and take meds at home? Or do you do better with a more formal appointment?
Yeah.
And then what's your schedule like too?
And this takes us into the question of adherence, and then the fun story about the first time we all remember being together, if you haven't heard the intro episode. But recently, a new form of immunotherapy that has come out is something called oral mucosal immunotherapy. And that is a similar process. We call it OMIT. So it's sort of a similar process as far as the allergen getting into your body as the sublingual, but it's done by brushing your teeth. And it's fascinating because when they look at adherence between SLIT and OMIT, which are both done at home, the first dose in your allergist office, the data for OMIT adherence is like in the 80%, and SLIT was something like 60%. And it's because when you do the OMIT, you literally replace assuming that you're one of those people that follows the dental guidelines of brushing your teeth for 2 minutes twice a day. You replace one of those brushings with the dental toothpaste. It's a proprietary toothpaste that allergens are put in, and there are cells in your mucosa that then take it to the immune system, similar to the SLIT. And that seems to be something that people can do that has similar efficacy to SLIT, but could potentially be something you could fit into your routine more easily, assuming you're a normal toothbrusher. But we all think that there's a method that is the most easy, I would say, out of all of these. And that's, again, the first memory we all have of being together.
Yes. Yeah. So we talked about how important it is for us to know that the treatments we're recommending to our patients are convenient for them, are things that they're actually going to do so that they can feel better. And so ILIT, Intralymphatic Immunotherapy, is a newer form of immunotherapy. It's not new by any means. Intralymphatic injections for treatments of different things, infectious disease, oncology, have been researched and used for 75 plus years. But for treatment of human allergy, research started about a quarter century ago across the pond in Switzerland. And as new faculty, when I started on faculty at Ohio State and Nationwide Children's, my research interest was intralymphatic immunotherapy. I had just learned about it, thought, okay, I guess I need to explain what it is first. But it's essentially, instead of doing an allergy shot under the skin of the arm, it's using ultrasound guidance to find a superficial lymph node and then injecting directly in the node. So you're directing into this protected space where you're not, when we do traditional shots injecting under the skin, we know we're injecting into a space that has mast cells, which cause allergic reaction. But with this intralymphatic, we're bypassing that. So it should be a safer procedure. And because it's a more efficient delivery system of going right to the lymph node where these antigens are going anyways, we can do this in 3 injections over 8 weeks. 1 injection every 4 weeks. After the 3rd one, you're done. And studies have shown similar effectiveness as the 3 to 5 years of traditional shots. Adherence is close to 100% for most patients. And when we look at all the studies done at adherence on SCIT and SLIT, it really varies. The average is around 50, 60%.
I was going to say if you're lucky.
At best.
Yeah.
And when we think about all the wasted resources for people that start a course of SLIT or SCIT, and maybe after a year, they decide they can't keep coming to our office that regularly, or they move, they have to basically start over wherever they go somewhere else. So ILIT is really the immunotherapy of the future for our patients. And what do you guys think about
Well, I
ILIT?
would like to point out to our listeners who may not realize this, that Dr. Amber Patterson is quite a big deal in the ILIT world. So she's selling herself a little short, and I'm sure she just is humble and doesn't want to express this, but she was the first person in the entire world to do ILIT research on children and adolescents. And that is a really, really amazing thing. And so we're extremely proud to know her and to have learned from her. She started her own private practice. Can I delve into this?
Yeah, sure.
So I was in an academic practice for 9 years before I decided to leave private practice. And I'd always told Amber, when you're ready to teach other doctors how to do ILIT, I want to learn. And so,
Same.
Yeah, right. It's sort of what brought us together, because the first time when we were talking about this started in Switzerland, Dr. Patterson during our research had a researcher come over who's one of the first pioneers of ILIT and do a talk, and we were all together at different stages in our work, training careers, and that's sort of one of the initial things that we bonded over. But it is such an amazing thing to have such an expert at our fingertips. And so when she got to the point that she was teaching other doctors and doing it through this new innovative way with a learning network where we all can benefit from each other, if you want to talk a little bit more about that.
Sure, yeah. Well, and you guys were all part of bringing this together. So you deserve credit for that, because as we sat down as peers and said, okay, if this is something new that's not taught in the traditional fellowship program, how do we bring this to the U.S. and teach other doctors in a way that is responsible and standardized and safe for patients? And so we decided that we needed to come together and form an active learning network. So the Auni ILIT Learning Network is a group of allergist physicians who we all follow the same rigorous training protocol, become certified ILIT providers, and follow the same treatment protocols. We get together in meetings and discuss, how is this working for our patients? Do we need to be changing this or that? What can we do better? How can we track how this is working for our patients? Just contributing to the science of this newer treatment. Definitely not new. I mean, we've been doing it in the Columbus area for over a decade. You guys have been doing it over a year.
18 months.
Yeah. I
a few years.
Your first licensee period.
Yep.
And then Carol helped pioneer the program at Ohio State, which was the first academic institution to join the Auni Learning Network.
So really exciting time for patients, and something that I think a lot of patients don't know about yet. So just know your options. Like Kara said earlier, know yourself. Like what type of treatment is something you're going to stick to? Because if you're not going to stick to it the whole treatment, then it's almost not even worth starting in the first place.
Absolutely.
So we hope that we gave you some ideas for different ways you can naturally treat your allergies with immunotherapy between SCIT, SLIT, OMIT, and ILIT. The quality of those treatments is really important, so make sure that the allergist you see is properly trained, certified, and providing effective dosing. And we thank you for joining us on Allergy Actually.
Make sure to comment leave your questions below, and then check out the show notes. If you are interested in exploring these treatments, we will make sure to list some resources to connect you with people who are within the Auni Learning Network, and so that you can learn more and
potentially get the therapy yourself. That's our goal. We want you to feel better.
Till next time.